All right, here we go with another fun chapter on the nervous system. So today we're going to look at the peripheral nervous system and reflex activity. This is a fairly long one. So with your peripheral nervous system, you're going to have sensory receptors that are going to either come in via a cranial nerve or a peripheral nerve from the spinal nerves. They'll come into the brain, and then the motor output is going to go back into the peripheral nervous system and send the message to the skeletal muscles. So again, this is showing the reflex here coming in to the receptor, coming up to the brain for perceptual level processing, and then you'll send the motor influences back out. So together with the brain, the spinal cord forms the CNS. This is going to go through the vertebral column of the foramen magnum, and it will start at the foramen magnum at the top, and then it goes down to about the level of L1 or L2. So things that you'll have occur here, you do have some spinal cord reflexes. You have integration or summation of inhibitory and excitatory nerve impulses. What that means is if you have an excitatory and an inhibitory come in, they're kind of balancing out there. And it provides a highway for up and down travel of the sensory and motor information. So here you can see where there is the spinal cord on the inside. It's protected by bone. There's also cerebral spinal fluid, ligaments, and meninges. With the meninges, you've got the three layers, the dura mater, arachnoid mater, and pia mater. So if you're going from the vertebrae, then going deep, you have the epidural space that's filled with some fat. It's going to give some cushioning. You've got the dura mater, and it's dense irregular connective tissue in a tube. The subdural space will have interstitial fluid. Then you have the arachnoid mater, which is that spiderweb layer of collagen fibers. The subarachnoid space will have your cerebral spinal fluid. And then finally the pia mater that's going to adhere directly to the tissue. So the spinal cord is a flattened cylinder. It's 16 to 18 inches long. It's about 3/4 of an inch in diameter. So on my female hand, with comparison from what I've seen, it's a little bit bigger than between my pinky and a finger in diameter. In the adult, it ends at about L2. So when a spinal tap or epidural or lumbar puncture is done, they're usually done about the level of L3 or 4 to avoid hitting that area. In a newborn, it is going to end at L4. Growth of the spinal cord will stop at about age 5. There's two areas where you have enlargements that you can see on here. You've got a cervical and lumbar enlargement. This is going to be where it goes out to the upper limbs and the lower limbs. The conus medullaris is down at the bottom, and then the filum terminale is going to be where you have the pia mater extend on. And then when it comes down here, we call this the cauda equina. It literally means horsetails, that you're going to have fibers connect beyond there for lumbar, sacral, and coccygeal nerves. So this is showing that inferior end. The conus medullaris is kind of the cone-shaped end. The filum terminale, those are those thread-like extensions of the pia mater. As it comes in, it kind of stabilizes it. The cauda equina will have dorsal and ventral nerve roots of the lower spinal nerves. So the spinal segment is the area of the cord from which each pair of spinal nerves will arise. So what's going to happen is you're going to have some fibers come out from the anterior side and some from the posterior side, and they're going to come together here to make your actual spinal nerves. So your posterior dorsal root will have sensory axons. The anterior ventral root will have motor axons. So you'll have the posterior dorsal root ganglion that will come out to the spinal nerves. So inside the spinal cord, different types of things are going to travel in different pathways. So things that you have on the inside, the anterior and posterior, or you have the anterior median fissure, the posterior median sulcus, gray and white commissures, central canal, anterior, posterior, and lateral gray horns, anterior, posterior, and lateral white columns, your ascending or sensory tracts, and the descending or motor tracts. So this allows you to see these different areas in here. You can see where there's the sulcus, the horns, the dorsal nerve root ganglion, more of the horns, the anterior white commissure, and so on. And this is a photograph of an actual spinal cord here. So the gray matter is going to surround the central canal. It's going to have cell bodies of neurons and glial cells. There are groups of nuclei, sensory or motor, that are going to have specific functions. So your posterior gray horns are going to contain somatic and visceral sensory nuclei. Anterior gray horns will contain somatic motor nuclei. Lateral gray horns contain visceral motor neurons. So they're both motor. The gray commissures are going to contain the axons of the inner neurons. Those will cross from one side of the cord to the other. When we look at the white matter, it's divided into 6 columns. So we call them the funiculi or a funiculus. They'll have the tracts or fasciculi that convey the sensory information or motor commands. So ascending tracts, they're going to go from the spinal cord to the brain. Descending tracts are going to go from the brain to the spinal cord. So the easy way to remember that, brain is above the spinal cord in terms of going up and down. The commissural fibers are going to cross from one side of the cord to the other. So this shows those patterns here in the spinal cord. So these color-coded illustrations are a lot easier to see it on than an actual cross-section of a real spinal cord. It just doesn't have the pigment changes to be able to identify the spots easily. So when we talk about a nerve, we're talking about a single cell. Or actually, the nerve is the enclosed cable-like bundle that's going to have nerve fibers in it. A single axon is just a branch of a nerve, and the neuron is a single cell. So you'll want to make a correction here in the notes on these. Your neuron is going to be the cable-like bundle of axons. So with nerve cells, we generally refer to them as nerve fibers. So with your spinal nerves, you've got 31 pairs of mixed nerves. The cervical are numbered according to where they come out, C1 through 8, the thoracic, T1 through 12, and the lumbar, L1 through 5, the sacral, S1 through 5, and the coccygeal. So the roots are the points of attachment for each of these spinal nerves. Well, they'll attach to the segment of the spinal cord. So your posterior or dorsal root is going to have sensory fibers. So it's going to conduct the impulses into the cord. The dorsal root ganglion are going to have cell bodies of the sensory neurons. The anterior ventral root is going to have motor neuron axons. It's going to carry the impulses away from the cord. And then the cell bodies are located in the gray matter. So your connective tissue coverings of the spinal nerves, you'll have epineurium, perineurium, and endoneurium. And they'll divide up into fascicles. So similar to what you had with the muscles here, you can have these little fascicles that are surrounded by perineurium in the little bundles. So spinal nerves branch, and their branches are called the rami. So your posterior or dorsal ramus is going to go to the deep muscles of the skin of the posterior surface of the trunk. The anterior or ventral ramus will go to the upper and lower limb muscles and the skin of the anterior and lateral trunk surface. So a plexus is a network of axons, so they will come out and recombine. So your anterior rami, except T2 through 12, will form plexuses. The plexuses we have are the cervical, brachial, lumbar, sacral, and coccygeal plexuses. You have the meningeal branch of the nerve that's going to come off of the spinal nerve and re-enter into the intervertebral foramen to serve the ligaments, the dura, the blood vessels, the intervertebral discs, facet joints, and periosteum of the vertebrae. So here is just a cross-section showing these coming out, how you can have these rami coming off of the spinal cord. And again, showing sensory going into the spinal cord, motor going back out. Or I guess we got sensory coming in green, motor going out in red. So this is actually showing some of the larger nerves being removed out at a body's exhibit. So here you can see again, they come out, they're going to recombine, some of these rami coming off. And this is showing how they come off and where they will branch to. So looking at the nerve plexuses, they're complex interwoven networks of nerve. They'll occur in the segments that are going to control the skeletal musculature of the neck and the limbs. So the peripheral distribution of the ventral rami does not directly proceed to their peripheral targets. The ventral rami of adjacent spinal nerves will blend their fibers to produce the compound nerve trunks. Those are actually formed during development when the small skeletal muscles fuse to form the larger muscles with compound origins. So compound muscles contain sensory and motor fibers. The ventral rami converge and branch to form the compound nerves. So this is a nice picture of it here where you can see you've got C1, C2, C3 coming out, and that you've got some of them converging here back on each other. So the cervical plexus is formed by the anterior rami of C1 through 5. So the phrenic nerve is going to come from C3, 4, and 5. It's an important nerve from the cervical plexuses. You've got superficial sensory and deep motor branches. So the cervical plexus is going to cover the skin and muscles of the head and neck and the superior part of the shoulders and chest. So this just shows some of the nerves and which branches they come from. The brachial plexus, this is the one that most people usually get to memorize. It's formed by the anterior rami of C5 through 8 and T1. This is going to go to the shoulders and the limbs. It breaks up into roots, trunks, divisions, cords, and finally the nerves. So this picture here is a nice one showing how you start with the roots here. You have the trunks, the divisions, the cords, and how you finally end up with these terminal branches. So due to the number of injuries that will happen with the upper limb, that's why most people end up having to memorize the brachial plexus, is to try and understand the patterns that come in, whether or not you've got carpal or tunnel or if it's an impingement somewhere else. So this is another picture showing the trunks and cords. This one tries to make it a little bit more three-dimensional. So your long thoracic nerve is going to go to the serratus anterior muscle. The subscapular nerve is going to go to the supraspinatus and infraspinatus muscles. So one's out of the brachial plexus directly. Axillary nerve, this goes to the deltoid and teres minor muscles. The musculocutaneous, this is going to go to the coracobrachialis, biceps, and biceps brachialis, so anterior arm muscles. Median nerve is going to do muscles to the lateral side of the anterior forearm and hand, so the thenar or the thumb side. Remember, anatomical position is going to be with the palm facing up. Radial nerve is going to go to the posterior compartment of the arm, forearm, and hand. And then the ulnar nerve is going to go to the anterior forearm and hand on the ulnar side, so hypothenar. Some injuries to the brachial plexus. So Herb Duchenne palsy or waiter's tip, this involves C5 and 6. You have loss of sensation along the lateral side of the arm. So with wrist drop, this is a radial nerve injury. You have the inability to extend the wrist and fingers. So median nerve palsy or carpal tunnel syndrome, you have numbness, tingling, and pain in the palm and the fingers. It affects the thenar muscles, the clawing digits 2 and 3, loss of pronation and finger flexion, and weak wrist flexion. So ulnar nerve palsy, this goes through the tunnel of Guyot. There's the inability to abduct or adduct the fingers. It affects the hypothenar muscles, and you have a claw hand, digits 3 and 4. When you see a winged scapula, this involves the long thoracic nerve. You have paralysis of the serratus anterior muscle. So the arm cannot be abducted beyond the horizontal position, 90 to 180 degrees. So this is kind of showing what some of these things would look like here with the ulnar nerve palsy. You've got the claw digits in here. And then here you can see with the change in the winging of the scapula. Lumbar plexus, this is formed by the rami of L1 through 4. So this is going to supply the anterolateral abdominal wall, the external genitals, and part of the lower limbs. So your femoral nerves are L2 through 4, and then the obturator nerves are also going to come from L2 through 4. So some injuries here. Femoral nerve injury, you would have loss of thigh flexion and leg extension, sensory loss to the anteromedial aspect of the thigh and the medial side of the leg and foot. With obturator nerve injury, you have paralysis of the adductor muscles of the thigh and sensory loss to the medial thigh. So the sacral plexus is going to come from L4 to S4. This supplies the buttocks, perineum, and lower limbs. So the largest nerve in the body is going to arise from the sacral plexus. It's the sciatic nerve. It is really large in diameter. It's as large as your small finger. Injury to the sciatic nerve can result in pain from the buttock down to the back of the leg. You can have foot drop, inability to dorsiflex the foot, and loss of sensation over the leg and foot. So sciatica is inflammation of the sciatic nerve. It does not have to have all of these things when you have sciatica. So it can progress and gradually get to that point. Usually when somebody has sciatica, they're not real content to leave it alone. It's pretty uncomfortable. Some causes include herniated disc, sacroiliac subluxation, and piriformis syndrome. The piriformis syndrome is due to the piriformis muscle wrapping around it and getting too tight to irritate it. So the tibial nerve is going to be one of the branches off of the sciatic nerve. It's going to go to the posterior compartment of the thigh and leg, sensory information to the posterior thigh and leg, and to the sole of the foot. So then the common peroneal nerve will come off and branch into the superficial peroneal nerve to the lateral leg compartment, and it'll be sensory to the anterior leg and dorsum of the foot. The deep peroneal nerve will go to the anterior leg compartment and gives sensory information to the first digital web. So here you can see the nerves, how they come off and branch down into the leg. So the coccygeal plexus, this is going to be formed by the anterior rami of S4 and 5 of the coccygeal nerves. It supplies a small area of skin in the coccygeal region. Dermatomes, these are nice and easy to learn. It's going to be the area of the skin that provides the sensory input to the CNS. This is going to go through one pair of spinal nerves or the trigeminal nerve. So if you get an idea what the pattern is like, especially here with the rib cage where you've got these stripes on there, if you remember a couple of landmarks in there, then you can pretty much fill in everything else. And then it's kind of sectioned off with medial and lateral arms, so that makes it a little easier to do that in the sections. With the face, it's the trigeminal nerve, the back of the head, C2 and 3. And then with the leg, again, you kind of go into these little chunks of sections. And then when you get down to the lower leg, it splits into medial and lateral. And then you've got these sections again on the back with the fingers. You can usually go, okay, here is C7 right in the middle, and work your way around there. So sensation is when you detect a stimulus, whether it be from internal or external receptors. It can be conscious or subconscious. So what will happen is you'll have stimulation of the sensory receptor. You will transduct that stimulus through energy degraded potentials and generate your nerve impulse, which will lead to integration of the sensory input. Perception is the actual awareness and conscious interpretation of the sensations, so you can't perceive all of them. It's how the brain makes sense of what information it's getting. So there are some things that are very real that we cannot perceive: X-rays, ultra-high frequency sound waves, UV light. We just don't have any sensory receptors for them. So integration of the sensory and motor functions occurs in several places: the spinal cord, brainstem, cerebellum, basal nuclei, or the cerebral cortex. So if you have disruption of sensory motor or integrative structures or the pathways, you will disrupt homeostasis. So we have general senses and special senses. Within the general senses, you can have somatic or visceral. Somatic are going to be to most of the body. Visceral is going to be within the internal organs. So somatic senses, tactile or touch, thermal, pain, pressure, and proprioceptive, knowing where your body parts are in space. Visceral will let you know things like the pH, osmolarity, oxygen and carbon dioxide levels. So things you're not consciously aware of, it's going to take care of that and regulate it for you. Then your special senses, you have a special sensory organ for them: smell, taste, vision, hearing, equilibrium, and balance. So we do have alternate classifications. You can do them based on their structure, their type of response, their location and origin of stimuli, or the type of stimuli. This classification up here is what is used most commonly. So if we look at their structural classification, free nerve endings have bare dendrites. So these are the ones that will do pain, temperature, tickle, itch, and light touch. Encapsulated nerve endings, the dendrites are enclosed in a connective tissue capsule. These would be pressure, vibration, and deep touch. And then some have separate sensory cells. These are going to be vision, taste, hearing, and balance, your special senses. So here you can see the difference in the structures. So free nerve endings, this bulb here around it are encapsulated, and then you've got these separate cells for the special senses. So with a free nerve ending, here going to skin, bones, internal organs, joints, here to the deeper muscle tissue. This is showing some of those free nerve endings in the skin versus a Pacinian corpuscle and a Meissner corpuscle. So we can classify them by the type of stimuli. Mechanoreceptors, they're going to detect pressure or stretch. So touch, pressure, vibration, hearing, proprioception, equilibrium, and blood pressure. Thermoreceptors detect temperature. Nociceptors detect damage, and these result in pain. Photoreceptors detect light, and chemoreceptors will detect chemical molecules, so those would be things like taste, smell, and changes in your body chemistry. We can classify them by location. Exteroceptors are near the surface. They're going to receive external stimuli, so this would be hearing, vision, smell, taste, touch, pressure, pain, vibration, and temperature. Interoceptors are going to monitor internal environments. They're not conscious except for pain and pressure. And then proprioceptors sense body position and movement, so your muscle, tendon, joint, and inner ear. And then by response to stimuli. So generator potentials, here the free nerve endings or encapsulated nerve endings, and olfactory receptors produce generator potentials. So when it's large enough, it generates a nerve impulse to a first-order neuron. With receptor potential, this would be things like vision, hearing, equilibrium, taste receptors that will produce receptor potentials. They release neurotransmitter molecules on a first-order neuron to produce a postsynaptic potential. So that postsynaptic potential may trigger a nerve impulse. So the amplitude of the potentials varies with the stimulus intensity. So this is just a nice summary of the classifications. So adaptation. Most sensory receptors will exhibit adaptation. It's the tendency for a generator or a receptor potential to decrease in amplitude during a maintained constant stimulus. So an example of this would be if you put on glasses or you're wearing jewelry, after a while you don't notice them. So some of the receptors may be rapid or slowly adapting. Rapidly adapting receptors detect pressure, touch, and smell. They're specialized for detecting changes. Slowly adapting receptors detect pain. You get to keep that one longer. Body position, chemical composition of the blood. So nerve impulses continue as long as the stimulus persists. So it makes pain hard to ignore. Change in sensitivity to long-lasting stimuli can lead to a decrease in responsiveness. So eventually bad smells disappear. You don't notice them as much. Very hot water will start to feel only warm. You can actually have that happen a little bit more with cold water too. And then potential amplitudes decrease during a maintained constant stimulus. So your somatic sensations, these would be your sensory receptors in the skin, for cutaneous receptors in the muscles, tendons, joints, and inner ear. These tend to have uneven distribution of receptors. You'll have more in the tongue, lips, and fingertips. And they pick up four modalities: tactile, thermal, pain, and proprioceptive. So just kind of an awareness thing, proprioception is also called mechanoreception. So these are the sensory receptors of the skin. You've got the Merkels, or the type 1 cutaneous mechanoreceptors, Meissner's, Ruffini, or type 2, hair root plexus, and the Pacinian. So the Meissner's corpuscles, they're an egg-shaped mass of dendrites. They're enclosed by that capsule of connective tissue. These are rapid to adapt. They're in the dermal papillae of hairless skin, like the fingertips, hands, eyelids, the tip of the tongue, lips, nipples, soles, clitoris, and the tip of the penis. Hair root plexuses are rapidly adapting touch receptors in hairy skin. They're free nerve endings that wrap around hair follicles and detect movement on the skin that disturbs the hair. The Merkel's discs or tactile discs are known as the type 1 cutaneous mechanoreceptors. They're slow to adapt. They're saucer-shaped, flattened, free nerve endings. These are going to be in fingertips, hands, lips, and external genitals. Ruffini corpuscles, also called the type 2 cutaneous mechanoreceptors, they have an elongated, encapsulated receptor. They're in the deep dermis of the skin, also in ligaments and tendons. They're found in hands and soles of the feet. Your Pacinian or lamellated corpuscles, they're a large oval structure. They have multi-layered connective tissue capsules that will enclose a dendrite. They're fast-acting. They're found around joints, tendons, and muscles, in the periosteum, mammary glands, external genitals, pancreas, and urinary bladder. So thermoreceptors, they're going to pick up two distinct thermal sensations, warm or cold. Pain sensations, these are going to involve nociceptors. Pain is protective. It's to try and stop you from injuring yourself. There's two types, fast and slow. Fast pain is your acute, sharp, prickling pain. Slow pain is more of the chronic burning, aching, or throbbing pain. Referred pain is felt in or just deep to the skin that overlies the stimulated organ or a surface far from the stimulated organ. So the pain that you're feeling it's not coming from where you think it is. An example of referred pain would be when a person has a heart attack, referring pain to the jaw or into the arms. Phantom pain is pain that feels like it's coming from a body part that's no longer there. So this is showing some of the referred pain patterns. These can be kind of interesting. So proprioceptive, these receptors are slow to adapt. It's going to give weight discrimination. There's 3 types: muscle spindles, tendon organs, and joint kinesthetic receptors. So muscle spindles, they're interspersed among most of the skeletal muscle fibers and aligned parallel to them. They measure muscle stretching. So they'll consist of intrafusal muscle fibers. They're specialized muscle fibers with sensory nerve endings and motor neurons called gamma motor neurons. Extrafusal muscle fibers are going to surround the muscle fibers, and they're supplied by alpha motor neurons. So this is showing here a muscle spindle and tendon organ. So tendon organs are located at the junction of a tendon and a muscle. It's going to protect the tendons and their associated muscle from damage due to excessive tension. So they'll have a thin capsule of connective tissue that will enclose a few tendon fascicles. Joint kinesthetic receptors, they're found within or around the articular capsules of synovial joints. These include your free nerve endings and Ruffini corpuscles in the capsules of the joints, and they respond to pressure. Pacinian corpuscles, these are going to respond to the acceleration or deceleration of joints during movement. So this is a somatosensory map of the postcentral gyrus. So you can see on here, they've taken body parts and drawn them on the outside of the brain in areas that are close to where they would be on the brain, and they make the body parts size proportional to indicate how sensitive that is. So you can see you get a big hand and big lips on here. So some of this mapping can actually be modified a little bit. You can, when a person learns to read Braille, they're going to have a larger area representing their fingertips as a result of the adaptation of relying on the fingertips. So when we look at the motor pathways, the CNS is going to issue the motor command. It does it in response to some sort of information provided by a sensory system, and that will be sent by the somatic nerve system or the autonomic nervous system. So with the somatics, it's going to lead to skeletal muscle contraction. If it's autonomic, it's going to go to a visceral effector. It might be smooth or cardiac muscle or a gland. Motor pathways usually have 2 neurons. So in your somatic nervous system, the upper motor neuron has the cell body within the CNS. Lower motor neurons that are located in the motor nucleus of the brain stem or the spinal cord, and only the axons extend to the effector. They can have different clinical presentations. With the autonomic nervous system, it's either the preganglionic or postganglionic neuron. So upper motor neurons send information to the lower motor neurons that will go to the skeletal muscle. So these neural circuits involve the basal ganglia and the cerebellum to regulate the activity of the upper motor neurons. The lower motor neuron is the final common pathway because you'll have several regulatory mechanisms converge into this final peripheral neuron. So the direct motor pathway, it's going to originate directly from the cerebral cortex. This would include the corticospinal pathway that will go to the limbs and trunk. The corticobulbar pathway goes to the head. The indirect motor pathway originates in the brainstem, and it's going to include synapses in the basal ganglia, the thalamus, the reticular formation, and the cerebellum. So when you have paralysis, there's two different types. Flaccid paralysis is damage to the lower motor neurons. There's no voluntary movement on the same side as the damage. There's no reflex. The muscle's limp and flaccid. You have a decrease in muscle tone. With spastic paralysis, you have damage to the upper motor neurons. The paralysis is on the opposite side from the injury. You have increased muscle tone and exaggerated reflexes. So when we look in the motor areas, again, we have the similar pathway here that you did with the sensory areas. They're located in the precentral gyrus of the frontal lobe. More cortical areas devoted to the areas that have muscles involved in skilled, complex, or delicate movements. So a reflex is an immediate involuntary response to a specific stimulus. So the neural writing of a single reflex is referred to as the reflex arc. It's the pathway. So they're classified according to their development. Is it innate or acquired? The site where the information processing occurs. So is it a spinal or cranial? The nature of the resulting motor responses. So are they somatic, visceral, or autonomic? And the complexity of the neural circuit, monosynaptic or polysynaptic. So this is just showing different ways of classifying them. So the reflex arc is your pathway followed by the nerve impulse. So it's going to include the sensory receptor, sensory neuron, the integration center, the motor neuron, and the effector. So here you can see your stimulus, putting your finger on a tack, coming into the sensory neuron. It's going to reach the inner neurons. It's going to let the brain know what happened as well with that connection. And then you're going to have the motor neuron go out and send the message, so you pull your hand off of it. And this is just another picture showing this same pathway. So a stretch reflex causes contraction of a skeletal muscle in response to stretching of a muscle. It's monosynaptic. So you have your patellar or knee jerk reflex. You have stretching of a muscle that's going to activate a sensory receptor, the muscle spindles, the sensory neuron, the integrating center in the spinal cord, the motor neuron, and the effector. What it's going to do is it's going to say, I don't want this stretch too much. I'm going to contract the muscle to prevent that from happening. It's ipsilateral. It occurs on the same side, and it's going to cause the agonist muscle to relax. So here you can see this with this reflex here with the reflex hammer coming in. You're going to have it stretch the sensory receptor, sensory neurons excited. You have the inner neuron here. It's going to send it out to the motor neuron, and the muscle is going to contract and relieve the stretching. The tendon reflex is a polysynaptic reflex. This will control muscle tension by causing a muscle to relax when the tension is great. So your sensory receptors are Golgi tendon organs. Where there's increased tension applied to the tendon organ is stimulated, sends the nerve impulse to the spinal cord, and the motor neuron causes muscle relaxation to relieve the tension. So it's an antagonist muscle contraction. And this is showing that happening as well. Flexor withdrawal reflexes, these are polysynaptic, they're ipsilateral. So if you step on a tack, that's your stimulus, the nerve impulse is going to cause activation in the inner neuron, the motor neuron, and you're going to pull your foot off the tack. So if you have little kids, you've probably done this with the Lego. The crossed extensor reflex, it's polysynaptic, it's contralateral. So you're going to have contraction of the muscle that extends the joint of the opposite limb. So that way, when you step on the tack or the Lego and you pull one leg away, it's going to make sure the other leg stays down so that you don't fall. So reflexes that are commonly checked: the patellar reflex, looking at the knee jerk; the Achilles reflex, ankle jerk; plantar flexion reflex, Babinski sign, and the abdominal reflex. So reciprocal inhibition, muscles on one side of a joint are going to relax to accommodate the contraction of the other side of the joint. If you are contracting the biceps, the triceps are going to relax to allow that to happen. So that happens automatically when you're not really thinking about it. You can consciously choose to contract both of them, and in that case, then the joint doesn't move. Hyporeflexia is below normal or absent reflexes. So you can use reflexes to help in the diagnosis of disorders. So if it's absent, it's usually not pathological. If it's absent unilaterally, the damage may be somewhere along a nerve pathway. And if you have hyperreflexia, it's suggestive of a brain abnormality. So generally, additional testing is done. This is just your first clue to help decide what kind of testing you need. Clinically important reflexes: the biceps for C5, triceps for C7, the patellar for L4, Achilles reflex for S1. Babinski sign, it's a pathological reflex. It's normal to see in a kid, but not in an adult. And the abdominal reflex. So when we have nerve injury in the brain or the spinal cord, it can be permanent. And it's going to be followed by spinal shock. So this loss of reflex activity is called areflexia. Electrical stimulation to promote regrowth of damaged neurons and specific nutrition may help. Anti-inflammatory drugs are usually given at the time of the trauma to try and decrease the swelling. So spinal cord injury can result in paralysis. So it's based on the limbs involved. Monoplegia is one limb, diplegia is two, paraplegia is both lower limbs, hemiplegia is one side, quadriplegia is all limbs. You could have complete transection or hemisection. Mature neurons are amitotic, meaning they're not going to divide. If the soma of a damaged nerve is intact, the axon will regenerate. This will involve having coordinated activity among the macrophages to remove the debris. Schwann cells need to form the regeneration tube and secrete growth factors, and then the axons regenerate from the damaged part. The CNS oligodendrocytes have growth-inhibiting proteins that prevent CNS fiber regeneration. So here it's showing you've got the axon becomes fragmented at the injury site. The macrophages are going to clean out the area, so you have the dead axonal area removed. Then you're going to have the axon sprouts or filaments grow through a regeneration tube formed by the Schwann cells. Your axon regenerates and you'll make a new myelin sheath. So that's what happens there. For the cranial nerves, there's 12 pairs of nerves that are associated with the brain. Most are mixed in function. 2 pairs are purely sensory. So each nerve has a name and a Roman numeral, 1 through 12. There are several mnemonics for them. One of them given here is, on occasion our trusty truck acts funny, very good vehicle anyhow. Cranial nerve 1 is the olfactory nerve. It's a sensory nerve that's going to cover your sense of smell. Your olfactory cells then converge to become the olfactory nerve. 2 is the optic nerve. It's also a sensory nerve. Ganglion cells in the retina of each eye are going to join to form the optic nerve. This is the nerve of vision. Oculomotor nerve. This is a motor cranial nerve that will originate in the midbrain. This is going to supply the extrinsic eye muscles to control eye movement of the eyeball and upper eyelid. The trochlear nerve is a motor nerve. It's the smallest of the 12. It's going to originate in the midbrain. It controls eyeball movement. The trigeminal nerve is the largest cranial nerve. It's a mixed nerve. It's got 3 branches, the ophthalmic, maxillary, and mandibular. It's going to deal with the sensation of touch, pain, and temperature. Your motor axons are going to supply the muscles of mastication. So the abducens nerve, motor and cranial, it's a motor cranial nerve that originates from the pons. It's going to cause abduction of the eyeball, lateral rotation. So you've got 3, 4, and 6 that are all going to involve eyeball movement, and different muscles are going to be controlled by different nerves, so it will control the eyes going in different directions. It's the reason for doing the cardinal fields of gaze test. So your facial nerve, it's a mixed cranial nerve. You've got the sensory portion that will extend from the taste buds, so it does the anterior 2/3 of the tongue. The motor portion is going to come from the pons and deal with facial expression. Vestibular cochlear nerve is 8. It's a sensory nerve. It originates in the inner ear. The vestibular branch is going to carry information for equilibrium, the cochlear branch for hearing. The glossopharyngeal nerve is mixed. Sensory neurons are going to carry the taste buds from the posterior 1/3 of the tongue. It's where bitter flavors are. Motor neurons are going to arise from the medulla and deal with the release of saliva. So the gag reflex is also carried by the glossopharyngeal nerve. The vagus nerve, it's a mixed cranial nerve. It's going to come from the head and neck into the thorax and abdomen. So your sensory neurons deal with a variety of sensations, proprioception, stretching. The motor neurons arise from the medulla. They're going to supply muscles of the pharynx, larynx, soft palate. Swallowing and vocalization are going to be controlled here. The accessory nerve is a motor cranial nerve. It's divided into the cranial and spinal accessory nerves. It's going to supply the sternocleidomastoid and trapezius to help coordinate head movements. Hypoglossal nerve is motor. It's going to conduct nerve impulses for speech and swallowing. So this shows where they come off on the bottom of the brain. They are in order from front to back, which makes it a little bit easier to remember them and identify them. So this section here is just reference extra details on the cranial nerves. I tried to kind of separate out what I felt was reasonable for testing material, but also give you some additional reference in here. So with these, you're welcome to go through and read them. This is just some additional reference information for some more detail on the different tracts in the nervous system. Again, I am not going to test on it, but it's there for your own personal reference. But that's going to wrap up this section of the nervous system.